Now let's go through and talk about the age-associated changes when it comes to function in the cardiovascular and pulmonary systems. So in your handout, you have the table that summarizes this information. I'm only going to hit the highlights. I want to show you a couple figures that may help you understand the concepts better. So if you haven't had the concept of reserve pounded in your head yet, this is a good way to look at it. Okay, so this will make more sense as we go. But if you look at the resting line, at rest, the aerobic capacity, our VO2, it goes up a little bit as we age. It costs a little bit more energy to be at rest due to some of these alterations or changes that have taken place in our body. At the same time, our maximum mobility declines. Okay, and we'll talk about those reasons, and they're in your handout too. So there's a loss of reserve to do activities as we age. So we lose a little bit of that reserve. So again, you look at 3 different activities. You can still do the activities here, but they might be closer to your maximum at this later age versus at this younger age. Let's first talk about some of the changes in the vasculature. We know that there's stiffening, hardening. So what does that mean? Resistance goes up. And because resistance goes up, flow will drop according to Ohm's law. But we can't have flow drop, right? So what has to happen? Pressure has to go up. So this is why we might see an increase in blood pressure at rest, partly because of this resistance. And there's a range of different reasons, but this is part of it here. We may see resting heart rate increase. We'll talk about in a minute. Probably not so much because stroke volume is going to stay the same, but you may see that. Activity, we may have to extract more oxygen from the blood as it goes to the vessels because our cardiac output will be less. We'll talk about that here in a minute. This is a figure. I don't know if it fits here, but I always like to show it. You see this arterial stiffness and thickening. What happens is the left ventricular reserve goes down. Okay, so we see our ability to increase ejection fraction for the left ventricle goes down. At the same time, what happens is it increases, causes hypertension, hypertrophy, ischemia, and then increases our risk of heart failure and stroke. So stroke volume, let's talk about stroke volume for a few minutes. As you clearly remember, I know stroke volume is end diastolic volume minus end systolic volume, and you see preload, afterload, and inotropic effects all determine that stroke volume. Okay, so that should be a quick review for you. What we see during functional activity is really no change at rest due to compensations. So what happens is we use the Frank Starling or the Starling principle, is we put more stretch on the muscle fibers, which then creates a more forceful contraction to cause stroke volume to go up. Now, the downside of that is we're using some of our reserves, some of our ability to respond when we might need to during exercise. So we don't have that when we start exercising. What happens to stroke volume when we start exercising or doing activity? It will increase. It will increase as we expect it to, just like a younger adult would. But the potential for a higher stroke volume is less, and we're going to have a lower stroke volume at our maximum level because of these changes. Heart rate typically does not affect, or aging typically does not affect heart rate at rest because stroke volumes remain the same. The big thing is we see during activity. So we have a slower rate of increasing heart rate during activity because of the responsiveness of the adrenergic system. We also have less pacemaker cells, which can impact this. Because of this, we have less heart rate reserve. So think about your age-predicted max heart rate. It declines as we age. That's because of some of those structural and cellular changes that take place. So our maximum heart rate is going to be decreased as we age. What does this mean for cardiac output? Well, at rest, again, it's going to stay relatively the same, maybe just slightly higher, but relatively the same. But we have less of an ability to increase it during activity because stroke volume is less and heart rate is less. We do compensate by maybe extracting more oxygen from the hemoglobin, but not enough to make up for these age-associated changes. Ventilation and respiration. A series of changes take place, and the most important thing is this down here. Okay, we see this right here, the pulmonary efficiency. This goes down through the aging process, become less efficient because of all these changes, okay? Other things that happen in the lungs, just to point out, this is a nice graphic to look at, is our total lung capacity really doesn't change that much because of aging. But what does increase is our residual volume. So the air left in our lungs goes up because of the narrowing of the airways, the air trappings, etc. So then residual volume goes up, there's more air trapping, we're not getting new air in as much as we'd like. Partial pressure of oxygen, because of the changes in the alveoli and the vessels, the pulmonary capillaries, what we find is our partial pressure of oxygen at rest is going to be lower, okay? It's going to be above the 60 that we're so concerned about, okay? So we think up here, it will be above this at rest, but it's going to be closer to that point. And this is an equation that you might see to predict PaO2 based on aging. And I plugged in a couple of ages. So 25, we're pretty close to 100. 55, we see 85. Even at 75, we're at 77. So still pretty far away from that 60. But you see, what's the theme you're seeing? You're losing some of that reserve. When we look at ventilation and respiration more, this is just more of a, I guess, a side comment to keep in mind. We have to breathe harder to dissipate that CO2 that builds up because of more dependence on our anaerobic system. We're a little bit slower in how we get up to a steady state for the oxygen, for using the aerobic system. So we have to rely a little bit more on anaerobic in the beginning, and we see a faster buildup of CO2 we have to dissipate. Overall, though, breathing is more taxing. It's harder to breathe. We lose efficiency. But when someone exercises, it's typically not ventilation as the limiting factor. So ventilation, respiration is not going to be what limits an older adult from exercising in most cases. It's going to be more cardiac related. Overall effect on aerobic capacity. You know, what are we going to see in our patients and our clients? Well, we see a lower VO2 max in older adults. So why is that? Well, decreased due to cardiac adaptations, heart rate's down, max heart rate's down. Our ability to get up to that max heart rate's a little bit slower. Pulmonary changes don't have that big of an increase or effect, as you see. What do we see? VO2 peak or max will decline about 3 to 6% per decade for the fourth and fifth decade. And after 70, we might see a 20% per decade decline. We see an increased rate at age 45. And not only does this affect the maximum levels, but affects the relative intensity of submax workload. And we'll talk about that a little bit more in the next unit. Again, it takes longer to reach the aerobic steady state, so then we depend more on the anaerobic system, and it might take us a little bit longer to recover. So bringing it together, age-associated changes leave an overall decrease in maximum work potential. Elderly will reach their maximum capacity at lower rate of work in comparison to younger adults, less responsive, and they need more time to adapt to workloads. So you can also think about the Fick equation and place these functional changes under each component, right? As stroke volume and heart rate change, so does cardiac output. As ventilation, diffusion, delivery, and extraction of oxygen change, so does our arterial and venous oxygen content, which leads to an overall reduction in VO2. Okay, so this brings this unit to the end. Hopefully this mini lecture here supplements what's in your handout.